following episode is brought to you by the American Urological Association. This episode features content from the AUA2026 meeting in Washington, D.C. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. Support for this activity has been provided by independent educational grants from Merck & Co. Inc. and Pfizer Inc.
Good morning, everyone. Welcome to today's focus on metastatic urothelial carcinoma. My name is Jen Jane Liu, and I'll be your moderator today. This is presented by the American Urological Association, and we definitely want to offer these outstanding educational courses, so please provide evaluations and feedback at the end so we can keep improving our programs. We have three outstanding faculty with us today in this course. First here is Dr. Bogdana Schmidt, who is a urologic oncologist at the University of Utah Huntsman Cancer Center. And then next is Dr. Mamta Parikh, who's the medical director of GU Oncology at the University of California at Davis. And then last but definitely not least, Dr. Dimitar Zlatev is a urologic oncologist practicing at Urology of Nevada. And they are going to be our expert panelists today. The disclosures are located on the AUA website for all of our course faculty, and we'd like to thank Merck and Pfizer for providing independent educational grants to support this activity. All right, so as I was mentioning earlier, welcome to this focus course on metastatic urothelial carcinoma. My name is Jen Jane Liu, and I work at the Oregon Health and Science University, and really the stars of today's talk are the three distinguished panel members that I introduced earlier. A really great group of people, and they're going to help us get through this evolving but very exciting topic. We have several objectives. So we're going to review guidelines-based options for systemic therapy and metastatic urothelial carcinoma. We'll discuss the role of consolidative local therapy in metastatic disease. We'll address some of the common non-oncologic urologic problems that arise in patients with metastatic disease that we all deal with. And we'll review some biomarker-driven systemic therapy choices. We're going to do that in a case-based format, and we have three cases here. Our first one will be involving cancer that's spread to the lymph nodes, and we'll be talking about systemic therapy, consolidation, and then a little bit about ctDNA. In the second case, we'll be discussing malignant obstruction and some of the sequelae of that. And then the last case will be patients who metastasize after having local therapy. We'll touch a little bit on variant histologies and therapy sequencing. So case number one. This is a 70-year-old man with a history of high-grade T1, so lamina propria invasive urothelial carcinoma, who has been treated with multiple intravesical therapies, and then after several years was lost to follow-up, didn't come back, and returns with hematuria. We do a cystoscopy. He has a 6-centimeter papillary bladder mass. And we do a transurethral resection, and it is high-grade urothelial carcinoma, albeit with some squamous differentiation, and it is positive for muscularis propria involvement. He has excellent kidney function and overall functional status. He is a heavy smoker, as you can see, and does have some urinary tract symptoms with nocturia ×3 being the most bothersome. We obtained a staging CT chest, abdomen, and pelvis, and you can see that there are several para-aortic lymph nodes that are rounded and suspicious looking and are over 1 centimeter by size criteria, as well as down here in the pelvis, there's another lymph node here in this obturator fossa that also appears abnormal. In addition, he has the large bladder mass, but fortunately no other visceral metastases. So I'd like to ask the urologist who, when this patient comes to your office, what would you do next?
Thank you so much. So for a patient like this, you clinically have suspicion that Oh, I can take this one. You clinically have suspicion that this is metastatic disease. The patient obviously already had a TURBT. You know that this is urothelial carcinoma. Squamous differentiation, possibly speaking to the fact that this tumor has been in situ for a long time, given the loss to follow-up. Now, for me, I don't have a lot of doubt that this is the same process in the pelvis and up in the retroperitoneum. The nodes are above the common iliac, so this is not someone that I would usually consider as locally curable with just surgery alone. So this is a patient I would discuss with my medical oncologist. And sometimes in a situation like this, especially if a patient had been lost to follow-up for a long time, a PET scan can be enough to convince my colleagues to say, look, this is the same process, we need to initiate systemic therapy. Sometimes they will try to pursue a biopsy, especially if there is a mixed picture. If you think the patient maybe even has a small lung nodule, big smoking patient, you want to make sure it's not a separate cancer. But in this situation, I think we would discuss neoadjuvant therapy and we'll assess response at that time. But with the disease that we're seeing now, this is not someone I would consider locally curable at this state.
Dr. Zlatev, you have anything to add? Do you have preference for imaging versus biopsy? And does the number of lymph nodes or suspicious areas play into that?
Yeah, I would. I agree with everything. I would get certainly a PET scan at this point. To provide that additional staging. The biopsy would be very challenging. It's a relatively small node, a couple of nodes around the aorta, and might just be non-diagnostic. So I agree. I would favor proceeding with the multidisciplinary discussion and planning for neoadjuvant treatment after getting that PET scan. And then as far as the number of nodes, yeah, there are 2 nodes above there, but the one in the nodal disease in the pelvis is certainly resectable and will be part of any kind of template. And nodes above, we would see how they would respond to treatment. So you're not obligated to go for a biopsy.
Great. So, yeah, we actually did pursue a biopsy of that pelvic node. But you're right, there are a lot of times that these nodes are nestled in these very difficult locations, and it really depends on sort of the mettle of your radiologist in terms of if you can get tissue. The advantage to getting the tissue is, you know, you can perform some type of genomic analysis, because that can help target your therapies. But if not, you're absolutely right, a PET scan is perfectly acceptable. And we do those all the time. I'm sorry. Okay, so we do that. And then, you know, this confirms that the patient has metastatic urothelial carcinoma. And so there are 3 main systemic therapies that are an option in this patient. And I just wanted to ask maybe Dr. Zlatev, you can comment on sort of, you alluded to it a little bit, sort of the location of the lymph nodes, right? In this patient, they had some in the para-aortic region and then some also in the pelvis.
Yeah, as far as systemic therapy here, I would favor the first option.
Would you still consider this sort of a neoadjuvant setting in this case with the nodes above the aortic bifurcation?
Yeah, absolutely.
I would say for me, anything above the commons is something that I would think of as metastatic disease. So I agree with you, right? When we used to do larger node extensions and an extended lymph node packet, we would take the nodes at the bifurcation and we would often go just a little bit above, not uncommonly after a neoadjuvant setting. But I think in upfront assessing this patient, I think that this is a very fine line trying to decide, is this patient someone we consider metastatic or regionally advanced?
And one might argue in the current setting with, as they say, all roads leading to EV Pembro, that maybe this distinction has become less important, right? And yeah, so I think this highlights an evolving point as the systemic therapy changes. But as you point out, metastases that are above the iliac, above the aortic bifurcation, that is considered M, or metastatic disease. And then when you're below that, you're technically in the pelvis, and so that's N3. And that does per staging change you between being a 3B or a 4A. So at this point, again, with systemic therapy kind of having on this common pathway for enfortumab plus pembrolizumab, it's maybe not as important of a distinction, but what you're talking about is downstaging in a neoadjuvant fashion versus systemic therapy. But again, with the therapies kind of all converging now on one common pathway, it's not maybe as relevant of a distinction, but there is a difference in stage there. And I think that is relevant in terms of how you're counseling the patient about their likelihood of cure as well. And then, Dr. Parikh, do you want to guide us through this slide about the systemic therapy regimens in de novo metastatic disease?
Yeah, I will say I agree with you that I think it's actually very important how we counsel patients in this setting, because even though the NCCN guidelines state that you can downstage at that stage, it all depends on whether you're having a response to systemic therapy. And those are not patients who have been studied in all of the perioperative or neoadjuvant trials to date, but these are two trials that we have in the metastatic setting. So one is the Checkmate 901 study, which only enrolled patients who were cisplatin eligible and randomized them to receive gemcitabine, cisplatin, and nivolumab versus gemcitabine and cisplatin alone. Had an overall survival benefit to the addition of nivolumab. The objective response rate was 58% with a 22% complete response rate, but the median overall survival was around 22 months. This is in contrast to the enfortumab vedotin plus pembrolizumab study, which randomized patients regardless of cisplatin eligibility, so they got in the control arm either gemcis or gemcitabine plus carboplatin. And this also showed an overall survival benefit, but you can see those curves separated out quite a bit more. The overall survival, median overall survival was around 32 months in this study, and the tail continues on, and the objective response rate was 68%, with nearly a third of patients having a clinical complete response. So as Dr. Liu mentioned, we are kind of moving towards an all roads leading to enfortumab vedotin plus pembrolizumab approach, especially because of that median OS data that we see.
And yeah, just to contrast that to the perioperative regimens that we're kind of looking at, you want to go through those?
Yeah. So a reminder that these studies took a perioperative approach, which meant that patients got neoadjuvant therapy. They proceeded to radical cystectomy, and then they received adjuvant therapy regardless of staging at the time of radical cystectomy in the experimental arms. So the Niagara study looked at gemcitabine plus cisplatin plus durvalumab, and then continued durvalumab in the adjuvant setting. The pathologic complete response rate with that study was 34%, but there was an overall survival and event-free survival benefit to this combination. Then the Keynote B15 or EV304 study looked again at EV-Pembro versus GemCis in the neoadjuvant setting, and the pathologic complete response rate there was significantly higher at 56%. And so again, I think that's why this is established as the frontline therapy. There was an overall survival benefit to this, and another study called EV303 looked at patients who were cis ineligible and saw a benefit compared to going directly to radical cystectomy. But patients on these studies continued EV-Pembro after radical cystectomy, which is an important consideration. And then, as I mentioned, this only allowed N0 or N1 disease in the study, so patients like our vignette of N2 to N3 would not have been captured in this study population.
Because traditionally we would consider them more metastatic, not necessarily surgery eligible. Though I agree with you, that line is shifting given the responses we're seeing, and the fact that you could see a clinical complete response at 30% for a metastatic patient is unbelievable. And we haven't seen anything like this with any therapies in any of our cancers.
And one thing I will also mention is that in both the Checkmate 901 and the EV302 studies, when you looked at lymph node only patients, they had even better responses, around 80% response rates in both of those studies. And the complete response rate was higher as well, in the 40s. So it's definitely a question that we're going to continue to grapple with about what to do with these patients that have excellent responses. I think the flip side of it is considerations for toxicities and whether you're eligible for treatment. So we've all over the years been hammered into our head about cisplatin eligibility, so everybody's aware of the limitations of cisplatin regarding renal function, underlying peripheral neuropathy, hearing loss, heart failure that's symptomatic. But then when you add in immune therapy, you also have to consider patients who have autoimmune conditions and are on immunosuppressive therapies. For those patients, immune therapy is not a good idea. With enfortumab vedotin and pembrolizumab, we can take away some of those contraindications of renal function and hearing loss and heart failure, but peripheral neuropathy is still something that we have to consider as an eligibility criteria. And then we add in that uncontrolled diabetes was not permitted on the trials looking at EV pembro because of the risk of hyperglycemia.
Great. It's an ever-changing smorgasbord of side effects that we have to try and keep track of. So thank goodness for our medical oncology colleagues. Dr. Zlatev, can you comment a little bit? You've practiced in both more community-based setting and an academic setting, and some of the differences in how you manage these types of patients in both?
Yeah, so the difference in management, we try to keep it to a minimum, of course. I mean, we have these excellent new treatments. And what we try to do is you want to bring the academic center to the community, but it's the challenge is the coordination, how to do that. So at an academic center, we all come from, where we train and Epic, everything is coordinated. There is, nurse managers, there's social workers. All of that is really incorporated in the same system, so the patient can come and see their medical oncologist on floor 5, get their labs, go down to the urologist on floor 2. If they need radiation, they could go to their radiation oncologist all in the same spot, get their imaging. That is not the case in the community. And, most urologists will practice in the community, more than 80%, and I think the numbers are similar for medical oncologists. So the challenges that we experience is with coordinating all this. And when you're working with multiple offices, so a cancer, a medical oncology office, a radiation oncology office, and then yourself. These are 3 different entities, and you just have to establish these relationships and do the coordination a lot yourself. So I actually end up doing a lot of, circling of numbers. This is who you call, this is what you do, this is where you go. Just put it in your calendar, but then I'll have a patient, pull out a flip phone and and some of them don't even have internet, or they live like 2 or 3 hours away. So we have resources. Insurances actually do help with travel. We also have some foundations that we set up for the patients to help them with that. But the issue of coordination is the biggest one, and you just end up doing a lot of that yourself with the medical oncologist and their office.
Great, thank you for highlighting those challenges. And then we did kind of touch on this briefly. Dr. Schmidt, do you want to comment on, now that when you think a patient has metastatic disease, it's a little bit of a different categorization, and how you go about bringing up local therapy or cystectomy in that setting versus maybe in a more neoadjuvant or peri-op setting in localized disease?
It's definitely a different conversation, I think, with a lot of patients, even in their mind, when they come in and the disease is, quote, the cat's out of the bag, then local therapy becomes less of a forethought. And only in the idea that could we then maybe decrease some systemic therapy by removing the local disease, or could we decrease their burden of symptoms from the bladder, if they have any, by removing the bladder. But I think the idea that removing the bladder improves their overall survival in the metastatic setting is extrapolated. There's no data to answer that particular question. So it becomes really patient by patient, and a conversation between the surgeon and the medical oncologist saying, well, if they're having trouble tolerating their treatment and most of their disease everywhere else has responded and it's really just the bladder, can we take the bladder out and maybe decrease how much therapy they get in the future or give them a little bit of a holiday? Then it might make sense. Or if the patient is having symptoms from the bladder, then again, that might make sense. But if a patient had a good response, is continuing on therapy, they're doing well, their quality of life's good, I may hesitate to remove a bladder in that situation.
Yeah, I agree. I think it's totally different than what it used to be. You used to be, if you saw metastatic disease, it was kind of game over, right? And you really wouldn't spend very much time discussing that as an option at all. And with more effective therapy, I think that kind of gets back on the table, although I agree with you, the evidence is lagging. So this gentleman completed 4 cycles of enfortumab plus pembrolizumab. He tolerated quite well without any issues. Urinary symptoms got better. And then he had a circulating tumor DNA assay that pre-treatment started at 15 and then post-treatment dropped down to 2.2. So, Dr. Puri, could you kind of guide us through what that means to you and how you use that to manage their treatment?
Yeah, so these tumor-informed ctDNA has become a very popular test that a lot of patients ask for and a lot of physicians like to order because we like more data, but it is important to note that these have not been validated in prospective trials, especially in the metastatic setting. However, there are a lot of emerging retrospective data that have been reported that these are small studies that I highlight here that show that both steep decline in ctDNA as well as a quick decline in ctDNA are correlated with better prognosis. What does that mean in terms of how we can predictively figure out what to do with these patients? We're not sure yet, but definitely seems like a good prognostic indicator. And I think the question is how to incorporate these into our management in a prospective trial is probably something that's needed.
Yes, I feel like it's like a lot of things. I mean, in the past, bladder didn't have quite as much data overload, but sometimes I feel like it's turning into prostate,
Yes.
Lots of data, not sure what to do with it.
Including the anxiety that patients experience with PSA rises. It's very similar with ctDNA
more
rising.
does not necessarily make people feel better. So this patient has repeat imaging, and all of the lymphadenopathy in both the pelvis and the retroperitoneum resolve. There's still a large mass in the bladder, and now I think I would ask both Dr. Zlatab and Dr. Schmidt, would you be brief and then we can go on to the next, but would you offer local therapy to this patient?
Yeah, absolutely. I mean, so this patient has biopsy-proven metastatic disease thanks to the biopsy that he got before his treatment and has responded to the systemic therapy, but has persistent local disease. So I would offer local therapy now.
How about you, Dr. Schmidt?
Yeah, I would. These cases are challenging sometimes, but they're also doable. And again, for selected patients, if they still have a persistent mass in the bladder, there's nothing else anywhere else, I think cystectomy is reasonable. I think the tumor burden's a little low, and cystectomy is not a great idea. You can consider radiation in that patient, especially if they have some hematuria where you're really trying to decrease the bleeding, but there's not a significant tumor burden, and they're not a good cystectomy candidate. That's also an option. Again, there's not a lot of data in this space, but it is a situation we're having to encounter and discuss in our multidisciplinary tumor boards, and I find that we do offer local therapy to these patients.
Can I ask my urology colleagues an anecdotal question? Because we are using enfortumab vedotin and pembrolizumab so much more, I have heard anecdotally that there are differences in surgical experience with that.
I might sometimes get upset with you guys when we're in the operating room.
That's what I'm curious if
That's
you can
been my
share.
experience, that a small percentage of them have this extraordinary desmoplastic reaction. It's not dissimilar to what you do sometimes see with combined checkpoint blockade and renal cell carcinoma as well. And interestingly, anecdotally, sometimes there'll be something totally plastered and that will come back
CR.
Yeah, as a CR. And then, of course, then you're thinking like of all the hours you spent chipping that off whatever named vessel. But yeah, that's been my experience, but it's not everybody. And I think it might have to do with duration of therapy as well.
Your point, I mean, I think you hit it, it's off a vessel. I think it's never with the tumor. It's never the cystectomy. It's the lymph nodes. It's the lymph nodes that used to be positive that responded to the therapy. It just melts into the vessels. And so the node dissection becomes really tough. And I think that's what people are talking about now is if we can figure out a way to predict whether those nodes are positive or negative, maybe we would spend less time chiseling them off.
Before we turn it into cancer.
I totally agree. It's the iliacs, and they're plastered on them. And when I'm doing that, I just tell myself that this is good. There was a reaction. I'm just going to keep going and do it. But I think it's actually response to treatment.
Yeah. Yes, we're still ever so grateful. Dr. Parikh, for the more effective medicine.
I know. I
just don't get the wrong idea.
I heard similar stories, so I thought it was worth sharing. Yeah.
I just added this slide because in my training, we always learned that cytoreductive or consolidative cystectomy in the metastatic setting was not something you did, that it had poor outcomes, and that the patients didn't do well. And I really do think that as we evolve toward more effective systemic therapy, that could be changing, and although we do need more data to back that up. And this is actually as modern of a cohort as I could find from the National Cancer Database. It wouldn't cover the EV-Pembro era because it ends in 2019, but it does include people who had chemo and then consolidative radical cystectomy versus what they called conservative local treatment. So my guess is that includes things like TURBT, palliative radiation, things like that. And they did actually see a survival benefit if you had cytoreductive cystectomy, particularly if you only had one lymph node, although even with multiple, that was observed, a benefit was observed, as in our patient, or even a single visceral metastases. Now, take an NCDB retrospective study for what it is, with significant limitations, but I think this is sort of an example of the changing role for us in the face of more effective systemic therapy. And then I think we were going to talk a little bit about the idea about consolidation for chemo-rads, as Dr. Schmidt said. How do you guys select patients for that or recommend that?
Yeah, I mean, I guess having a great multidisciplinary team is really the key, and you're going to hear that over and over, but talking to your radiation colleagues, your medical oncology colleagues. And for me, honestly, if I've made the decision that the patient needs local therapy, and I think they can tolerate a cystectomy, then that would often be my preference, because then you get the path to. Then did they actually respond? It gives you better staging. It helps you guide the next steps of their therapy and how much more they might need or not need. But if the patient's not fit for cystectomy and has some local therapy, or you really want to consolidate to try to cut down their systemic burden, then discussing with my radiation oncology colleagues a chemoradiation or a radiation alone plan. But our preference in our institution is a chemo-rads approach, not radiation alone.
And this is a slide just showing that consolidation with radiation is also an acceptable consolidative therapy, particularly in patients with oligometastatic disease. But again, a small retrospective study. And then, Dr. Parikh, did you want to discuss this slide that?
Oh, sure. So I think this is a study that will be looking at whether there is a role for radiation in combination with enfortumab vedotin in patients. But this is in a more localized setting, no distant metastases. So they'll get enfortumab vedotin and pembrolizumab for 2 cycles, and if they have either a complete response or a partial response, they go on to receive radiation and enfortumab vedotin. There's another study, a SWOG study called the BRIGHT study, SWOG 2427, that's looking at patients who, again, have a clinical complete response, but it's more regimented, where you have to actually go in and get systematic biopsies to prove that there's no disease. And those patients get pembrolizumab plus radiation on that trial. So I think there's going to be some very interesting emerging data. Both of these trials exclude the patients that we're talking about who have known node-positive disease that's outside of the local zones. So I think there still needs to be additional trials still that are going to look at the metastatic setting.
Great. So this patient does elect to have a cystectomy and ileal conduit with pretty substantial residual disease burden in the bladder only. And so even though his urinary symptoms got better, it felt like he was a good operative candidate, and that he might have fewer long-term issues without leaving that bladder and tumor intact. There was a big mass in the bladder, but the pelvic adenopathy looked resolved. And fortunately, the lymph node dissection was not as challenging as it normally does. It can be in this situation. Dr. Zlat have thoughts about extended lymph node dissection in the setting of having those para-aortic nodes. Do you do those?
We used to do that, yeah.
Yeah, we spent a lot of time doing those in our
a lot of time
right?
doing, going above the aorta, but I think when in this patient with resolution of lymphadenopathy outside the true pelvis, I wouldn't do a super extended lymph node dissection, but I would take it up to the aortic bifurcation.
So he fortunately has an unremarkable postoperative course, and his final pathology is YPT2, and the nodes were negative. And his ctDNA becomes undetectable postoperatively. So, and that's a nice outcome all around. All right, we'll move on. Next case, 74-year-old man. He has a 2.5 centimeter tumor that was diagnosed on a hematuria workup. And the tumor is known to be over the left ureteral orifice, has some cardiac history, significant for a heart attack about a year ago, prior smoker, decline kidney function with the EGFR 49, and some functional impairment as well, and pretty mild urinary symptoms. We perform a transurethral resection. He has high-grade urothelial carcinoma involving the muscularis propria, and a stent is placed at the time of the TURBT. Dr. Schmidt, do you have any preferences about stenting at the time of TUR?
I hate stenting. I have strong feelings about this, but I will say the data is mixed, and we'll discuss that a little bit. I think that for me, if I think this is a patient that's going to go on to get a cystectomy, I hate having a stent in there because it's going to make my life more difficult. I prefer to use nephrostomy tubes in those patients if you need to optimize their kidney function to get them through neoadjuvant therapy, which is less of an issue now with EV-Pembro, but it was more of an issue with cisplatin. I think that for me in the operating room, if I can resect the tumor and I can watch efflux and see that the ureter is not obstructed, I will omit a stent and get an ultrasound in a week and check labs in a week and make sure that that kidney and that side is okay, especially if a patient's going on for systemic therapy, because a lot of the time it'll actually improve as residual tumor, shrinks away. But if you're in a situation, of course, where you're worried that the ureter is obstructed, the patient's going to be in trouble overnight, then you do what you have to do and you put in that stent, and then you have to decide, are you going to keep it in for the duration of the therapy, in which case I usually do.
Yes. So I think that's also been my practice, that stenting has been associated. This was all sort of a theoretical risk, and then there was this recent
And I feel like, sorry to just go into this data, right? So if you look, there's a bunch of small retrospective studies trying to figure out are outcomes a little bit better with or without a stent. You're obviously trying to prevent a metachronous recurrence, so you don't want to seed the upper tract. But the problem with all of these studies, if you look at the cases, is they're very small numbers. And so you get one retrospective series and it's going to show maybe it's okay to stent, and you get another one and it shows, well, maybe it's not okay to stent. And so you really do need to do these meta-analyses aggregates to try and get a sense of where the reality is. And I think a lot of us feel maybe that it's, if you can get away with it, probably better not to stent from a metachronous standpoint.
Yeah, so I mean, I think that was always a theoretical risk, and then when they put this together, it does sort of show that the risk is pretty substantial, and so agree with trying to avoid stenting if you can, and then certainly with platinum becoming less dominant, that helps.
Yeah, just a quick word on. I totally agree. I absolutely avoid stenting unless really necessary to deobstruct someone with a very bulky kind of tumor that almost goes into the ureter. And yeah, those numbers, actually, we finally have some numbers. So it's something like around 7% seeding of the upper tract with a stent, 2%, 2 to 3% with a nephrostomy tube, and essentially, I mean, that data says 0% for people who have neither, but If you can avoid that, you also in the community, you save yourself nephrostomy tube exchanges, which you have to coordinate. IR is not going to coordinate that, or stent exchanges for a patient who might have a difficult time doing that anyway.
Yeah, I think this has changed my practice significantly. This was in the pre-EV Pembro, so that patient did actually get a stent. But yes, I agree. I think that now that you're not, because he had kind of a borderline or low GFR, so we were trying to optimize it so that he could get to the to a potential platinum eligibility. So, I think that EVP kind of changes that. He has a staging CT chest that unfortunately shows this lung mass that is very suspicious for a metastasis. Although solitary lung nodule in a man who has a history of smoking, certainly, don't forget about other potential causes like a primary lung malignancy. I will often try and get biopsies in those patients.
100%. I've diagnosed a lot of lung cancer.
Yes. And the PET doesn't necessarily help you, right? Because the lung cancer could be PET avid too. And then, we restaged the abdomen pelvis and still having pretty significant hydronephrosis despite the stent. You can see that in the pelvis there being in decent position. And this is the other reason with stenting is that when they have malignant obstruction, it doesn't always relieve, I find. The stent doesn't always relieve it. And then his GFR continues to decline. And of course, now he's really not thrilled with his urinary symptoms. They were mild, and now we've made them much worse. Dr. Zlatev, would you do any other tests to help this not happy patient at this time?
I mean, yeah, at this point, they're having lower urinary tract symptoms, presumably from the stent, and it is, not working also. So at this point, you really want to, talk them into, like we discussed, the nephrostomy tube, which is more effective. It's more bothersome to the patient, but it's more effective as far as kidney function and would help resolve some of these lower urinary tract symptoms.
Do you ever do any other diagnostic tests, either of you, in this group of patients to see if the stent is working or?
You could do, you could do a nuclear medicine scan, so that would be definitive, so you can see if the stent is actually working, if you have obstruction or not. And it'll also differentiate your renal function, which gives you a lot more information as far as, what if this is a non-functional kidney, in which case you don't want to, poke it, and you could just remove the stent and focus on treatment.
And I do think with some of these patients, especially older men who have some amount of BPH, some of the hydro that you see is actually reflux up the stent. So they're not emptying their bladder well. And so PVR, I think, is really helpful in this setting because if they're not emptying their bladder well, they're refluxing up the stent. You see that hydro, and you know that the problem is actually it's not the stent, it's not the obstruction, it's the poorly functioning bladder.
All right. So next steps, this patient with low EGFR, newly diagnosed metastatic disease to the lung. Dr. Parikh, what should we do next?
Again, systemic therapy is definitely an option here. I think you do always have to consider how symptomatic the patient is and whether we're going to be able to get them through systemic therapy. So that's always a discussion with my urologic oncology colleagues. But enfortumab vedotin and pembrolizumab has such a high objective response rate that we do note that patients generally feel better once they start therapy if they respond to treatment, which again, a large percentage of them do. The NCCN has all kinds of other recommendations for patients who, for one reason or another, can't get enfortumab vedotin plus pembrolizumab, but it really is our de facto upfront treatment, especially for patients with renal insufficiency.
I've noticed that some of these patients will get recurrent infections. So say you take the stent out or you just decide not to stent and they have this obstructed kidney and they probably don't empty their bladder super well because it's an older person with BPH. And they get a lot of these recurrent UTIs that can result in therapy delays. And is that something that you experience a lot, Dr. Parikh, that you see that can kind of mess up the...
We do, and we might be discussing this later, but I will just mention that there are conflicting data about whether antibiotic treatment changes efficacy of systemic therapy, but at a certain point, if a patient's having recurrent UTIs, you just want to get them started on systemic therapy, because again, if the disease is the reason that they're developing systemic or urinary tract infections, the best course is for them to start systemic treatment. I think we're going to learn more about the gut microbiome and its role in treatment efficacy, and that's probably why you see some changes in antibiotics, but there have been multiple real-world data sets that show different outcomes in terms of whether it's beneficial or detrimental or neutral to be on antibiotics.
And the hypothesis there is related to change of the microbiome affecting the efficacy of immunotherapy.
Exactly.
Right?
I will say with some of these patients, and again, there's not great data for this, so I hesitate to say it a little bit, but I've used methenamine hiburate as a suppressive, basically, when a patient's had 1 or 2 UTIs, and I say, okay, I want to stop using antibiotics, and so I'll use methenamine just to alter their urinary pH, and I find that it actually helps decrease the frequency of infections and the need to use breakthrough antibiotics. Again, this is not studied in this exact setting, but it has been shown to be safe and effective in an elderly population to reduce frequency of UTIs, so I'll sometimes rely on that.
Great point. And so, obviously the consequences of malignant obstruction, we've talked about the infections, loss of renal function, particularly in a patient that's, in a neoadjuvant setting, you have a defined amount of time they're going to be getting therapy and be obstructed, right? When you move to this metastatic setting, it could be indefinite. And so they could lose that kidney's function over time. And whether or not that's really relevant to the patient's overall survival and outcome is, I think, a different discussion. It depends a lot on the patient. And then we talked a little bit on the panel about using a stent versus a nephrostomy tube and different ways to help manage their symptoms, optimize emptying, anticholinergics, everything that you can. I do think some of those patients actually do, the ones that already have really angry bladders from the big bladder tumor anyway, they actually do better than you'd expect with the nephrostomy tubes. And this is an interesting slide that kind of highlights, this is in the localized setting, but in the neoadjuvant chemo setting, where they looked at patients who had no obstruction, they had obstruction that was relieved by a stent or a nephrostomy tube in that middle column, or they had obstruction that was just monitored through their neoadjuvant. And this was out of Fox Chase. And they basically showed that, there wasn't a difference in the rate of discontinuation of, in this case, it would have been platinum-based chemotherapy, and that there really wasn't much of a change in their EGFR. And that a surprising number of patients, as you alluded to earlier, Dr. Schmidt, will actually resolve their hydronephrosis without any type of decompression, particularly if it's not very severe to begin with. So again, in patients that don't have very significant obstruction, that are have decent renal function, they really may not need any treatment for that. And that you really got a pretty minimal and disappointing increase in EGFR when you decompress these patients. Okay. So we will move on maybe to the last case. This is a 75-year-old man who was diagnosed with muscle-invasive bladder cancer with significant squamous differentiation, 70% on the transurethral resection. Great functional status, poor kidney function, EGFR of 30, and did not have any neoadjuvant chemotherapy because this was before the Enfortumab 303 study. So he had a radical cystectomy with an ileal conduit, which was uneventful. The final pathology showed T3 disease with 1 out of 32 lymph nodes that were positive. And I just wanted Dr. Precht to spend a minute to go over variant histologies and how we think about systemic therapy, because I think this comes up sometimes, and for me anyway, there's not a lot of strong data to guide us. And so could you talk about that a little bit?
Yeah, so again, there isn't a lot of strong data, but I think it is important to bucket these categories into 2 categories. And one is patients who have urothelial carcinoma, but they have aggressive variant histology. So these are the patients that we see with micropapillary disease, plasmacytoid or sarcomatoid differentiation. These patients arguably have changes in their prognosis compared to patients that have classical transitional cell urothelial carcinoma, but we treat them very much the same and hope that things will go okay. And that's probably because we just don't have enough data about how else to treat them. With non-urothelial histologies, a lot of it depends on whether it's pure non-urothelial or whether there's a mix. If there's a mix, it becomes a gray area, but pure non-urothelial histologies are treated based on extrapolation from similar tumor histologic subtypes. So examples of this are small cell carcinoma of the bladder. We extrapolate a lot of the data from small cell lung cancer, and so we treat with platinum and etoposide frequently and could potentially add atezolizumab based on small cell lung cancer data. With pure squamous carcinoma, we often extrapolate from the lung cancer data in this space or the head and neck cancer data. And in adenocarcinoma, we extrapolate from GI or colorectal regimens, with there being some data with Fulvox and FOLFIRINOX now in adenocarcinoma subtypes. So the systemic treatment is very different. This is for metastatic disease. A lot of times, if it's not small cell and it's pure non-urothelial histology, will often annoy you all to do something surgical because we're not confident in our ability for systemic therapy to be effective.
Great. Thank you so much for going through that. And then did you want to go through this
Yeah, so
slide
this
as well?
this is some, again, retrospective data looking at variant histologies and how patients did this, lumped in together patients that had aggressive variants and some that are considered maybe not as aggressive, but the long and short of it is that patients that were treated with enfortumab vedotin had shorter progression-free survival or shorter overall survival if they had aggressive variant histology compared to those who had urothelial cancer. There's also data looking at enfortumab vedotin plus pembrolizumab in squamous differentiated, which again also shows that the patients do more poorly, but again, we don't know if they do any more poorly on platinum-based chemo. They just do more poorly on all the treatments we currently have. So I think this is an understudied group of patients, and Dr. Schmidt and I were talking before the session about how probably the next step is to get away from all of this nomenclature altogether and get towards molecularly selected patients where we figure out what's actually driving the tumor growth and target therapies based on that.
But I think that's a really good point, just to highlight this again, is that because all roads lead to EV-Pembro, there is this desire to throw EV-Pembro on every histology that you see because you kind of want to hope that it works. And we do now have very small series, but still we have data to show that these squamous in particular responds very poorly to it. So you might even be better off getting that patient straight to surgery as opposed to putting them through multiple cycles of EV-Pembro that their disease is going to progress on, and they're going to eat the side effects of these medications, which, wonderful when they work, are worth it, but not at all worth it when the disease progresses through it, and now the patient has worse neuropathy and other things that we'll discuss. So.
And for us, it's so in a non-academic center environment, I mean, the first thing that we will do with this would be to send the path to an academic center, because you really need a GU pathologist to look at this, a true GU pathologist to tell you, because there is a huge difference when you have a small portion of the tumor being the variant, which presumably doesn't respond or responds less to the systemic therapy, even the EV-Pembro option. But most of the tumor would, versus if you have something like 50%, 70%. And when you're dealing with, I totally agree, squamous, plasmacytoid, these are aggressive variants that traditionally respond less to systemic therapy, and the patient would potentially progress while they're getting their systemic therapy. So even if we go that route, once we've confirmed it with pathology and they choose, we would get shorter, like we'd get a mid-treatment scan just to see how they're doing, and have a short trigger for intervening with a cystectomy.
And I think to your point too, I think in the metastatic setting, when you see these mixed histology patients, if they have a response to EV-Pembro, those are the patients I present at Tumor Board more so to beg the urologist to consider surgical consolidation, because we worry that there's a micropapillary component left behind that's not responding to treatment. So can we surgically consolidate to get rid of those variant residual disease?
Great discussion. So this patient has a negative ctDNA post-cystectomy, and so opted for surveillance, declined any adjuvant therapy, maybe in part because of the functional status, and then gets the first CT scan at 3 months, and unfortunately shows pretty significant metastatic disease burden to the liver, the lung, which we didn't show here, and to also some enlarged lymph nodes in the pelvis. So that was unfortunate. It was a very short time to progression. And he gets started on EV-Pembro, and unfortunately, after 2 cycles, develops really severe neuropathy, probably had some at baseline, and just became really intolerable. And he has some new arm pain. We get new imaging, and it shows progressive metastatic disease to his bone. You can see here in the humerus, there's a lucency there, and there's also new hydronephrosis on the CT scan. And so then, of course, I opened this up to see what happens next after the EV-Pembro. And so usually when I see this, I just call my medical oncologist, and I'm like, help, right? And so then that's what I had this slide in here, and then Dr. Parikh was like, how about this one instead? And so can you walk us through a little bit about sequencing and how to make sense of all this?
I think the intent of the NCCN slide is similar to this. It's just easier for me to think through this way. And a lot of it basically hinges on what the first line therapy is that you received. So if the patient received EV-Pembro first line, then obviously enfortumab vedotin containing regimens are unlikely to be helpful, and it's arguable that further checkpoint inhibitor is unlikely to be helpful as well. And so those patients benefit most, as far as we know right now, with platinum-based chemotherapy. We only have limited data even in that space, and there's more that's coming. If a patient did get platinum-based immune checkpoint inhibitor combination like Gem/Cis/Nivo, then enfortumab vedotin as a single agent remains an option. We have previous trials that showed that platinum and IO refractory patients can still have response rates up to the 40% range with enfortumab vedotin monotherapy. There's some people that think you should continue EV-Pembro in that setting, and I don't think we have the data yet for that. It's also important at this stage to really start looking at next generation sequencing for patients, because if they do have targetable alterations, so FGFR3 mutations or FGFR2/3 fusion mutations, or HER2 immunohistochemical staining that's positive, then you have other options for treatment that also have good response rates with erdafitinib and trastuzumab deruxtecan. And then if you progress on all of these things, then taxanes and vinflunine are still options for you. The response rates for those are in the 10 to 15% range, so you start getting into the unmet need again. But there are a number of therapies that are available after progression with frontline therapy now. And I think we have a slide that goes through some of the data on Thor, which is a phase 3 study that looked at erdafitinib versus taxane chemotherapy. A third of the patients on this had gotten previous at least 1 line of therapy, and 2/3 had gotten more than 2 lines of therapy. Not that many had gotten EV, but you can extrapolate from this data the objective response rate with erdafitinib, and again, this is in FGFR mutated patients. The objective response rate was about 46% compared to 11% with chemotherapy, and there was an overall survival benefit. And similarly, on the next slide, there's data from the Destiny Pan-Tumor02 study that looked at trastuzumab deruxtecan, which is a HER2-directed antibody drug conjugate. And this was looking at a couple of different tumor types, but there was a urothelial cohort of 41 patients. And in the patients that had strong immunohistochemical staining of HER2, the objective response rate was 56%. And on that basis, the FDA approved this for any tumor that has high HER2 IHC expression. So again, that's an option for patients. There is variability in terms of immunohistochemical staining. And so again, that brings to mind the need to potentially send your path to an academic center.
And also to get the tissue, right? A lot of times we would see the metastatic disease and it was in a high-risk patient and you'd be like, okay, now what, right? But now there's actually something you can intervene upon with that tissue. So I feel like we're biopsying these patients a lot more frequently.
And in a lot of these patients, they actually did use archival tumor tissue. And so the question is, would you have seen an even higher response if you had a more recent biopsy that showed HER2 IHC expression in the most recent sample versus like a cystectomy specimen from a year prior?
Right, and that to that point, that this is really entering more of a prostate landscape, that when they have a metastasis, you want to biopsy the metastasis because the tumor profile might be different than what you had in the prostatectomy, and it's the same thing. You want to send the cystectomy when you have it up front, when you're making your first line choices, but once they've progressed, you want to have another biopsy. You want to send it off the bat, to the point that you want those biopsy specimens sent off often before you even send the patient to the medical oncologist, so that they can have a meaningful conversation about what the patient's options are.
Dr. Schmidt.
We can work together. We can work together.
It would be wonderful.
And that conversation that they're having is this one. And Mamta, can you educate us on these toxicities and how you manage them? I know there's a lot. So
the main thing to take away from this slide is that every drug comes with some trade-offs, and we're learning more about this toxicity. And unfortunately, as urology colleagues, you all are learning more about this too, because these treatments are going earlier and earlier in the staging of urothelial cancer. But checkpoint inhibitors, we worry about immune-related adverse events. The most common side effects are actually rash, which is manageable, and thyroid dysfunction, and then some fatigue and pruritus. So those are fairly manageable, but the ones that are serious will stay in your mind because you can get inflammation to any organ. You could get pneumonitis, colitis, autoimmune hepatitis. Happens in less than 5% of patients, but they'll stick with you. The common toxicities can be managed without discontinuation of checkpoint inhibitor, but those serious, less common ones do often lead to needing to discontinue therapy, as well as treating with high-dose steroids to calm that inflammation down. When you add enfortumab vedotin on top of that, you can have worse rashes because enfortumab can cause rashes by itself. So when you combine the two together, we have seen some more significant rash toxicities with this combo. Enfortumab can also cause peripheral neuropathy, which tends to happen the more that you receive treatment, which is why having our urology colleagues involved in potentially consolidative therapy that could get patients off EV is very attractive to patients, because the longer you're on it, the more toxicity you get. You can manage the peripheral neuropathy toxicity by taking a break from treatment and decreasing the dose of EV, whereas with immune checkpoint inhibitor, it's an on-off switch. There's no dose changes. Everybody remembers the side effects of platinum-based chemo, so I won't go too much into that. But these newer treatments, erdafitinib, can cause a lot of mucositis, GI toxicity, and hand and nail toxicities, which don't sound like a big deal, but can be a big deal when you have metastatic disease and have been on treatment for a long time. And trastuzumab deruxtecan can commonly cause cytopenias and GI toxicity, but about 15% of patients can get interstitial lung disease, which can be pretty devastating. So again, there's a lot of toxicity and new toxicities with these new mechanisms of action that we have to keep in mind for our patients.
So this patient, unfortunately, drops his eGFR even further to 15, probably because of that hydronephrosis, and then develops recurrent urinary tract infections. You've all had these patients. They're basically constantly calling your office. My urine smells bad. I have a UTI. They get in and out of the hospital with bad pylos. They're already frail. We do biopsy one of the metastatic sites, and fortunately, it shows that he's HER2 IHC positive. And so we send him off to medical oncology, and he initiates trastuzumab, but really just shows progressive disease, has a hard time getting the medication because he's in and out of the hospital for these infections, gets uremia from the obstruction, really having a decline. And so, Dr. Zlata, any thoughts about when you have a patient like this that you're kind of trying to help co-manage with these other urologic symptoms?
So it's very difficult to manage. I mean, especially, so this is a truly symptomatic patient with these recurrent UTIs. It's not one of those patients where, they have some bacteria in the urine, which will say, hey, that's just asymptomatic and we'll just guide this. Just hydrate more. I mean, they should hydrate more, of course, but it becomes very difficult. So the conduit patient, we would get some imaging to just assess what is the degree of obstruction. You could certainly do, again, a MAC3. It's not going to be very informative with such a low kidney function. You might not see what you want to see. You could, study the conduit. You can actually scope that and see if there is, whether there's like a nidus of infection there. Sometimes we'll see a stone at the staple line, but I'm sure that since you did the surgery, there'll be no staple line or stone like that. But I mean, they do form mucus. I know that we see that more with like continent diversions, but you could see some mucus be a source, and you could really kind of clean out the conduit. And then it's a lot about medical management. I mean, what are you going to do as far as urinary tract infections, and how does that interact with the systemic treatment? So they're never going to get systemic treatment if they're, febrile or have significant symptoms of a urinary infection. So I would treat this, aggressively based on cultures. You try to get as clear a sample as you can, whether it's from the conduit or from the upper tract, and treat it based on that, in the hopes that they resolve their UTIs and proceed with treatment. And then as far as the kidney function, I mean, you would have to consider nephrostomy tubes after this thorough evaluation, just to decompress them.
Sorry.
No, I was going to say, this is a patient who's suffering. Their disease is progressing. Their symptoms are getting worse. The urinary tract infections in and out of the hospital is horrific. And in this situation, I think it's also important to give the patient space to talk about what they really want at this point in their lives. Do they want to keep fighting for every possible moment that they could get with all of the interventions that Dr. Zlata talked about that might help, right? But you also want to give them space to say, I just want to be comfortable. I just want time with my family. And I think sometimes patients are afraid to bring that up to you as their doctor or as their surgeon because they don't want to let you down. And so I find that I often bring it up myself and say, look, I'm with you every step of the way. We're going to keep doing what you want to do, but I got to ask you what matters to you right now. What do you actually want? I can help you do that, and start from there.
Yeah, that's exactly what happened in this case. I offered him a nephrostomy tube, and then I also offered him an option to not do anything. And I think the more treatments you have, the easier it is to get on the merry-go-round, right? And he said, I just want to be able to go home and spend time with my family. I don't want to be in the hospital. I don't want to keep having PICC lines and antibiotics. And so he elected for palliative care and hospice. And I just bring that up. It's a sad ending to this case, but to kind of circle back that sometimes, especially I think as surgeons, we're not used to having those kinds of discussions. And I've certainly saw many times in my training where they're like, oh, you go talk to the medical oncologist, and then they would turn around and refer them to palliative care. But I think there is room, and that we do have the ability to do that, and we have these relationships with these patients that we've known them for a long time and cared for them, that it is okay to offer them that they don't want to do anything, and that they may not bring it up on their own.
I think it's also important, with all these new therapies that we have, we get very excited. But it is also always important to be talking to patients about prognosis, and you want them to have hope, especially with the new powerful drugs that we have. But this vignette was a patient that after only 2 cycles of EV-Pembro progressed, and we know those patients don't do as well, and it's time at that stage to say, like, there's still treatment options, but this is a more aggressive disease than we originally thought it was going to be, and kind of have to reset expectations along the way, too. So I think it is important from the medical oncologist standpoint that we have to take some ownership of that as well.
Great. So that concludes our 3 case presentations. Thank you for the excellent discussion. Our take-home messages are that, hooray, the new targeted therapies are much more effective. All roads seem to lead to enfortumab and pembrolizumab, at least for now. The role of consolidative local therapy, sort of once relegated to something that we would not really discuss. It's evolving, and that's probably in part because of more success in response rates with systemic therapy. More tissue biopsies, particularly in metastatic disease, than we might have done previously because of the ability to utilize biomarker-driven treatments. Malignant obstruction management is very complicated, and these are patients that will generate a lot of phone calls and hospitalizations. And so, think carefully about when to stent, how to manage the obstructions, some good strategies for recurrent UTI management as well. All of these new drugs are exciting because they're more efficacious, but they have all of these new side effects, and we have to at least understand what they are and recognize them, because sometimes you may be the one that picks them up. And don't forget about, even in light of all the newer, more effective therapy, there is still a role for palliative care, and we as surgeons can still play a role in helping guide patients to that choice when it's the right one for them. Thank you, everyone. Thank you to the wonderful panelists for making such a great discussion on a challenging topic, and appreciate all the audience participation. I think that I'm supposed to remind you to remember to share your feedback on the course evaluation, and that you can log into the AUA2026 site to claim your CME by December 31st. Thanks again, everybody.